Good morning and welcome back to our Journal Club review session. This morning we will look at a common intervention which had become the standard of care in intensive care practice, and that's stress ulcer prophylaxis. There was a time, or there is still a concept, that lack of provision of stress ulcer prophylaxis with proton pump inhibitors is a poor quality marker in intensive care units. Ever since the SuPICU trial was published last year, however, this paradigm seems to be shifting towards a more conservative approach to the use of proton pump inhibitors. So, based on the data that's coming in on the issue of the use of proton pump inhibitors, we look at the recently published PEPTIC study, and then we ask ourselves, do we become skeptic with the use of proton pump inhibitors after analyzing the PEPTIC study? Now, the PEPTIC study was published in the JAMA this year with the question, does stress ulcer prophylaxis with proton pump inhibitors have an edge over stress ulcer prophylaxis with H2 receptor antagonists? This is a big study which asks the clinical question whether what is the comparative effect on in-hospital mortality of using proton pump inhibitors versus histamine 2 receptor blockers for stress ulcer prophylaxis among adults who are admitted into the intensive care unit and have been mechanically ventilated. So let's look at the background against which this study has to be interpreted. An estimated 2.5% of adults acutely admitted to an intensive care unit will develop upper gastrointestinal bleeding. And in an attempt to prevent this gastrointestinal bleeding, 70% of patients who are admitted into the intensive care unit are prescribed stress ulcer prophylaxis of some sort. While proton pump inhibitors are the most commonly prescribed drugs for the prophylaxis, H2 receptor antagonists also are used with no definite proven advantage of one group over the other. The SuPICU trial that's published recently tried to analyze this issue and came to a conclusion that a higher 90-day mortality and a lower percentage of days alive without the use of life support in ICU patients at the risk of GI bleeding with a baseline SAPS-2 of more than 53 was seen in patients who are assigned proton pump inhibitors versus those who are assigned placebo. So this was not a comparison with proton pump inhibitors versus H2 receptor antagonists, but placebo controlled trial where the mortality with the proton pump inhibitors was reportedly higher. So the PEPTIC study tried to compare these two agents used for stress ulcer prophylaxis head to head. It's an international open label cluster crossover randomized clinical trial comparing two approaches for stress ulcer prophylaxis, and it's implemented in the intensive care units among adults requiring mechanical ventilation. More than 26,000 patients were enrolled and evaluated in this study from 50 ICUs in Australia, Canada, England, Ireland, and New Zealand. So these were, if you look at the distribution, these are ICUs where intensivists are the decision makers in the ICU, except probably in England and Ireland. We will go into that data as well. The population which this study evaluated was adults more than 18 years old who were enrolled into the study within 24 hours of admission to the intensive care unit and had to be mechanically ventilated. Those patients whose admission diagnosis included upper GI bleed were excluded from this study. Now, the intervention which was used was the open label use of any of the proton pump inhibitors or any of the H2 receptor antagonists as default routine prophylaxis in the 6-month blocks, which means that every 6 months the ICU changed from proton pump inhibitors to H2 receptor antagonists and vice versa. The endpoints which the PEPTIC study tried to look at were death, ICU discharge, development of a clinically important upper gastrointestinal bleeding event, and the treating clinician considered stress ulcer prophylaxis was no longer indicated. That's when the study period for that particular patient ended. The outcomes which the study ultimately ended up looking at were in-hospital all-cause mortality during the index hospitalization up to 90 days from the date of index ICU admission. And the secondary outcomes which the study attempted to look at were clinically important upper GI bleed, Clostridius difficile infection, and in hospital and ICU length of stay. Now, actually, if you go back into the background, the secondary outcomes were the initial primary outcomes which the study sought to measure, and the mortality was the secondary outcome. But they changed the sequence to mortality being the primary outcome, but this was done before any patient was enrolled in any of these centers. So if you look at the results of this study, close to 5,000 patients were available for complete analysis, and the mortality in both the groups, whether they received proton pump inhibitors or histamine receptor antagonists, was exactly the same, probably trending towards higher mortality for patients with proton pump inhibitors, the confidence intervals being quite variable. The secondary outcomes like the complications, the length of stay, or the duration of mechanical ventilation were absolutely head to head in these patients with either mode of stress ulcer prophylaxis. So there was no advantage of PPIs or H2 receptor antagonists over each other. So the authors concluded that among ICU patients requiring mechanical ventilation, a strategy of stress ulcer prophylaxis with the use of proton pump inhibitors versus H2 receptor blockers resulted in comparable hospital mortality rates, a difference that did not reach statistical significance. But the crossover problem of the study interpretation in the use of assigned medication could have been a confounding factor, is what the authors concluded. The strengths of the study, if you look at it up front, it's a big cohort, more than 26,000 patients across a wide spectrum of intensive care units. It's a multi-center study, and the questions they have asked are highly relevant, and appropriate research questions have been asked, and clinically relevant endpoints have been measured. So all those questions about the strengths of the study have been answered affirmatively. The weakness of the studies, however, it's a non-blinded study, so obviously it opens itself to the risk of bias. We do not know whether patients were already prescribed proton pump inhibitors when they were enrolled into the study. So either way, if they were already prescribed proton pump inhibitors and they continued to have proton pump inhibitors, the risk of their developing upper GI bleeds would have been lesser. On the other hand, if the patients were prescribed proton pump inhibitors for some other indication and they were suddenly withdrawn or changed to some other modality like the H2 receptor antagonist, there could have been a rebound bleed. So both these are confounding factors in the analysis of this study. Crossover rate seems to be a little higher, so we do not know attributable mortality interpretation, how reliable we can do it. The higher baseline mortality was seen in the ICNARC database, that is the patients who are in the UK and Ireland cohorts. Now that's something we need to look at, whereas the baseline mortality in the Canadian and the new ANZIC's ICUs was lower, the baseline mortality in the UK and Irish ICUs was a little higher, and that's something that's not explained. The comparable mortality of PPIs versus the H2 receptor antagonist compared to the previously accepted concept that proton pump inhibitors actually improved the survival could be interpreted as an increased risk of death with the use of proton pump inhibitors. As I said, there was a swap between the primary and secondary outcomes, but that happened before any patient was enrolled, so that should not be a major weakness of the study. And in the last aspect, the patients who are thought to be the highest risk of GI bleed were treated with proton pump inhibitors because it was left to the discretion of the clinician. So there is still a question of lack of equipoise in both the groups, or as the interpretation of data is concerned. We also accessed an accompanying editorial in the same edition of the JAMA on the peptic study. The editor's views were PPIs cannot be recommended as the default intervention to prevent GI bleed related mortality. An absolute increase in mortality of 0.8% with a decreased incidence in gastrointestinal bleeding of 0.5% is what has been actually elucidated by the peptic study. At the population level, a strategy of avoiding proton pump inhibitors in favor of H2 receptor antagonists could result in reduced mortality, but at the cost of an increased risk of gastrointestinal bleeding. And the motivation of this study, in the view of the editors, was a perceived harm with PPIs and not perceived benefit with H2 receptor antagonists. So there could be an intention bias in the study design itself. So these were the views of the editors. So looking at the data, looking at the results and the editorial view, the question is, will this change my practice of the use of proton pump inhibitors? There can't be a single answer. It's a yes and a no. Why is it yes? It's yes because I personally feel that proton pump inhibitors will no longer be the default stress ulcer prophylaxis of choice for my patients, and higher risk patients will not be treated preferentially with proton pump inhibitors. Why is the answer no? Stress ulcer prophylaxis will be given. What we choose to give is something we will have to make an individual decision, or we'll make a balanced decision. Till then, we will continue to give stress ulcer prophylaxis, but what we give is entirely our choice. There is no preference over stress of proton pump inhibitors over H2 receptor antagonists. Thank you and have a good day, and we'll meet again next week.